inviting me to present my talk. Today I am going to talk on Terminalia arjuna, modulates IL-18-induced inflammation in human monocytic cell line and in patients with stable coronary artery disease. And the background shows my institute, PJIMER it is called, and it is a premier medical education institute, National Institute of India. So inflammation, we know, inflammation plays a pivotal role in the pathophysiology of atherosclerosis, diabetes, and obesity. And there are various, besides other various risk factors which are involved here. And this talk is regarding that herbal medicines and nutrients may inhibit all these risk factors, and particularly inflammation, and we are trying to find novel biomarkers. So using a phytotherapeutic approach, we have conducted many studies, and with Terminalia arjuna, which is a medicinal plant, I'll come to it later, and we have conducted human clinical trial, animal studies in transgenic mice and rabbits, as well as in vitro studies to find out what it does to coronary artery disease. So WHO has predicted that from 7.2 million deaths in 1996, there are going to be 23.6 million deaths with coronary artery disease by 2030. So therefore, it has become a global epidemic of modern living. There are many proposed underlying mechanisms, and inflammation is the underlying culprit. And we know that it is the most important component of atherosclerotic lesions, and there is a crosstalk between monocytes, endothelial cells, and platelets, which forms a vicious cycle which perpetuates inflammation. So any kind of stress would lead to dysfunctional endothelium, which traps the monocytes, displays adhesion molecules, traps monocytes, which come to the subendothelial space, become macrophages, resident macrophages. They display scavenger receptors, engulf modified lipoproteins, and become the characteristic foam cells. And in this way, they elaborate so many pro-inflammatory factors, pro-apoptotic factors, and when they die, the lipid-rich necrotic core is exposed to the blood and thrombotic events start. So there are many medications and changes, and first doctors recommend lifestyle changes, and there are various medications where statins are used as the gold standard drugs. We know statins, they have a cholesterol lowering property, but besides that, they are shown to have many pleiotropic effects which are beneficial in coronary artery disease. But as the doctors see that in spite of improved lifestyle and pharmacological approaches with drug like statins, reduction in CAD event rates has never approached beyond 50%. Often the clinical outcome or response to therapy is poorly related to the signs and symptoms of the disease. And despite controlling for conventional risk factors, patients do come back with reinfarction, which could be only explained by residual ongoing inflammation and immune imbalance in these patients. Till date, there is no polypill or a single drug which exists in the market which offers a reliable, specific, and definitive cure and protection from the devastating effects of this disease. Therefore, it is logical to search for a remedy or a natural compound that may protect against endothelial dysfunction and immune imbalance, besides dyslipidemia, insulin resistance, etc. And we presume that dietary, nutritional, and herbal approaches can play a major role here. So this Terminalia arjuna, it is a native plant of India, and it is also very common in Sri Lanka and Myanmar. In ancient Ayurvedic system of medicine, Terminalia arjuna is known as a potential cardioprotective agent, which invigorates blood circulation and has hypolipidemic properties. Almost all the parts of this plant are used for medicinal preparation, and as we can see, the bark is mostly used, and it has active constituents like polyphenols, triterpenoids, saponins, phytosterols. It is rich in calcium, magnesium, zinc, and copper, and amino acids. So like statins, there are many reports in the literature that it is also anti-tumorigenic. It is antioxidant and a hypolipidemic plant. It is used for allergies, and our experiments have shown that it is anti-inflammatory, antithrombotic, and immunomodulatory. And most important, it is also vasodilatory. So it has many virtues like statins. So we proposed a hypothesis that any kind of external stress may lead to endothelial dysfunction, and due to oxidized LDL, it may lead into acute inflammation, which is very well known. And this oxidized LDL may activate UPR pathway, which through various genes may lead acute inflammation to chronic inflammation, and through apoptosis, it may lead to plaque progression and rupture. And just a little background, when we studied in coronary artery disease patients, we found very high levels of interleukin 18, which is a known pro-inflammatory cytokine, which causes inflammation and is involved in plaque progression and rupture. So IL-18 could be seen the underlying mediator of the disease, as it is involved in endothelial activation, endothelial dysfunction, plaque formation, and plaque rupture. So we decided that to see how Terminalia arjuna modulates IL-18 induced inflammation in human monocytic cell line, and validated our results in patients with stable coronary artery disease. So first we determined the time and dose dependent effects on the mRNA expression of key test genes, which were selected through microarray analysis. In stable patients of coronary artery disease, we did microarray and in silico analysis, and found that many of the genes were overexpressed and underexpressed. And on the basis of since my talk is today on the inflammation aspect of this, we decided to see how even IL-18 was highly expressed. So we decided to see how IL-18 modulates these genes and how Terminalia arjuna is effective in modulating these genes. Also, then we determined the time and dose dependent effects of Terminalia arjuna in IL-18 treated THP1 cells, and we also compared its effects with the standard drug atorvastatin. And to know the signaling mechanism which is involved in for the action of Terminalia arjuna, we studied signaling pathway. And this is the treatment protocol. I will not go it into further, but THP cells were stimulated with PMA first, and then time and dose dependent effects of recombinant IL-18 was done to study the viability and proliferation of THP1 cells. And what we found that at a dose of 40 nanogram per ml till 48 hours, it had no significant effect on the viability and proliferation of THP1 cells. Then in this, then we sought effect of recombinant IL-18 on mRNA expression of inflammatory and immunoregulatory genes, which were selected through microarray analysis. And we did time and dose dependent effects with recombinant IL-18 and did real-time PCR. Here I am showing the data of 4 genes: oncostatin M, DUSP1, which is dual phosphatase, dual specific phosphatase, and a chemokine, CXCL3, and COX2, which is a pro-inflammatory molecule. And here we saw that IL-18 in a dose of 10 nanogram per ml caused maximum expression of all these genes at 24 hours. So for further experiments, we took 10 nanogram per ml dose of recombinant IL-18 for our experiments. Now, in IL-18 treated THP1 cells, we did time and dose dependent experiments with Terminalia arjuna and compared its effects with atorvastatin. And we found that at the dose of 200 microgram per ml till 42 hours, Terminalia arjuna had no significant effect either on the viability or proliferation of THP1 cells. Therefore, this dose was chosen for further experiments. And to study the effect of atorvastatin dose was used based on our previous experiments, which were published in International Journal of Cardiology. And here you can see the comparison that with Terminalia arjuna and atorvastatin, we found that Terminalia arjuna significantly downregulated oncostatin M at 24 hours time interval, whereas atorvastatin had no significant effect on this gene. And chemokine was reduced both by terminalia arjuna as well as atorvastatin, but fold expression is much higher in terminalia arjuna as compared to atorvastatin. Similarly, dual specificity phosphatase 1 was significantly decreased by terminalia arjuna, whereas atorvastatin did not have that much effect. And COX-2, we are using COX-2 inhibitors, and we know it's a pro-inflammatory molecule, and interestingly, atorvastatin had no effect on COX-2, which could be responsible for the ongoing residual inflammation which is seen in patients with coronary artery disease, though they are treated with statins. And here terminalia arjuna was very effective. So here we see in the form of the table, and you can see the fold expression, that there was no significant effect of atorvastatin on either oncostatin M or COX-2, whereas it reduced chemokine and DUSP1. And the fold expression, the downregulation of these genes was much more by terminalia arjuna. Then with these IL-THP1 cells, we use signaling pathway inhibitors in a dose of 10 micromolar per ml for 2 hours and gave terminalia arjuna. And we again did the mRNA expression of the test genes, and we found that terminalia arjuna utilized NF-kappa B and MAP kinase pathways to signal its effects on these molecules in attenuating the expression of these molecules. So, concluding the phase 1 study results, we found that recombinant IL-18 in THP1 cell led to a significant increase in mRNA levels of inflammatory and immunomodulatory genes at 24 hours. Terminalia arjuna at a dose of 200 microgram per ml caused maximum attenuation in these test genes. And the most significant finding to note is that effects of terminalia arjuna were found to be thoroughly comparable, at par, and sometimes much better than atorvastatin. And terminalia arjuna acts through MAP kinase NF-kappa B pathways to induce its modulatory effects on these genes. Then we validated these results in patients with stable coronary artery disease, and we followed up the patients for 3 and 6 months, and ethical clearance was taken, and the clinical trial was registered. The date of first enrollment was in 2011, and completion of the drug trial was in 2012. And terminalia arjuna was bought from Himalaya, and method of it was a placebo-controlled double-blind clinical trial, and method of concealment was through coded identical containers, either A or B. And this is the inclusion and exclusion criteria for the controls and patients. Here I want to emphasize that only at the baseline we have compared normal healthy controls with the patients to know the difference in our patient population in terms of inflammatory markers. And for further, when we gave the drug, we have given the drug only to the patients. We had a placebo group and we had an experimental group. So these patients, since they were stable patients of coronary artery disease, the medications, they were on all sorts of medications for more than 3 months, including statins. So 120 patients were screened, 4 were excluded, they did not meet the criteria. 58 patients were allocated to drug A, and 50 patients were allocated to drug B. So we did not know which was the drug and which was the placebo. And then after that, 25 patients of both group A and group B, the real-time PCR validation was done for these 4 genes, both at 3 and 6 months. The primary endpoint of the study was to evaluate the effect of terminalia arjuna on hyperlipidemia, circulating immunoinflammatory markers, gene signatures as assessed by microarray in silico analysis in the 2 study groups from the baseline to the end of the follow-up. The secondary outcome was to study to assess the clinical safety and efficacy of the drug through major adverse cardiac cerebrovascular events. And we also studied the NOEL, that is no observable adverse effect level of this drug on kidney and liver function. So there was no difference as well as the sex ratio between the two study groups, and showing that both the groups were homogeneous. Decoding of the drug trial was done on 2012, and then we came to know that drug A is aqueous extract of Terminalia arjuna and drug B was visually matched placebo. And no significant differences were observed either between the Terminalia arjuna treated patients and placebo groups in terms of NOEL and MACE occurrence at follow-up between the two groups. And serum lipid and lipoprotein profiles were done. Whole genome analysis from the study subjects was done through microarray, and mRNA expression was done. And controls were enrolled at baseline only for comparison with the patient group. So if we see only between controls and patients, there was a significant difference only in the systolic blood pressure between the two groups. And of course, patients had more hypertensive smokers and alcohol intake was more, and family history of CVD was much more in the patient group. Now, lipid and lipoprotein profile between control and patient showed that total cholesterol was less in patients and LDL cholesterol was less in patients. You may wonder, but it was due to the effect of, it could be due to they were receiving statins. But triglycerides, they were much more in the study subjects, in the patients as compared to the controls. And in India and Asia, we have a more, triglyceride is much more in our Indian subjects, much more than the cholesterol level which are found in the Western population. So when we compared patients, there was total cholesterol and LDL was much more in patients, was less in patients versus controls. Triglyceride and VLDL cholesterol was more in patients versus controls. And there was no significant change in HDL cholesterol between patients or controls. Now, when we studied the placebo group as well as the group which was given the aqueous extract of Terminalia arjuna, we found that at 0 month there was no significant difference between the two study groups. That means most of these patients, they were all homogeneous. At 3 months itself, you can see that triglyceride levels reduced drastically in these study subjects which were given aqueous extract of Terminalia arjuna. HDL cholesterol, we had no difference, but VLDL cholesterol was also significantly decreased. At 6 months, we found that not only cholesterol levels decreased in the study subjects who were given Terminalia arjuna, but HDL cholesterol levels were also significantly increased. So when we saw that drug A versus drug B, when we saw the difference, triglycerides and VLDL cholesterol were much more decreased in patients who were on drug A versus drug B. At 6 months, triglycerides, total cholesterol as well as were decreased, and HDL cholesterol was also increased, whereas in placebo group it had no significant difference. Now we validated the same genes which we on the basis of our in vitro studies and microarray analysis studies, and we found that at 0 month between group 1 between drug A and drug B, there was no significant difference in the mRNA expression of these genes. At 3 months itself, the patients who were receiving Terminalia arjuna, there was a significant decrease in downregulation of these genes at the mRNA level, and at 6 months also fold decrease was much more evident. So we think on the basis of our experiments, as we proposed our hypothesis that Terminalia arjuna, it inhibits chemokine CXCL3, it inhibits DUSP1, PTGS, COX2 and OSM, and thereby does not let acute inflammation turn into chronic inflammation as well as apoptosis, and thereby prevents against plaque progression and rupture. So our data provides a scientific validation that terminally Arjuna is a cardioprotective drug because it showed active reversal of several molecular signatures of the disease as soon as 3 months itself, and its effect was maintained till 6 months. And it highlights the potent anti-inflammatory and immunomodulatory effects of terminally Arjuna, both in vitro and in vivo settings, and clearly supports and educates the use of terminally Arjuna as an adjuvant therapy. So I thank the co-guide of Ms. Divya Kapoor, who has done this work as her PhD thesis, part of her PhD thesis. Dr. Rajesh Vijay Varghia is a cardiologist who is our co-investigator, and this is our group of vascular biology in my lab. Thank you very much.
Thank you. We don't have time for questions. We need to get going to the next.
Okay,
Thank
next
you, sir.